Thanks very much, and thanks for inviting me here today. I'm going to talk about equity and inequality. I've been hearing about this from many people. So I'm going to touch off topics that we've heard over and over again, and I'm going to skim the surface of a lot of things here as well. That's hard to read, but it's from the latest UNDP, the United Nations Development Programme Human Development Index. So we're number 7. We're the 7th most developed country on earth, ranked 7th in the world at the moment. But there's a big difference in life expectancy. The development index is based on life expectancy, education, and gross national income. So it's wealth, knowledge, life expectancy is an indicator for health. There's a huge difference between life expectancy in the richest country and the poorest countries. And within countries, the most deprived, most disadvantaged people have much worse health outcomes from non-communicable diseases and communicable diseases than people with better social situations. And we know that we have big differences in life expectancy in Ireland, depending on where we live and whether we belong to a community such as the Travellers. And the Child Poverty Monitor published last week tells us that 1 in 5 children in Ireland is living in poverty. So we've talked about poverty, we've talked about children, and we've talked about what this means for the future. So what do we do when we see a child struggling or drowning? Globally, 20,000 children die from preventable causes every day. We all think this is wrong, and something should be done about it. And philosophers know that ask us why it's so hard to act. But many of these children are not identifiable. They're far away from us. It's no one person's responsibility, but it all just seems too difficult. So we're talking about complexity. We're talking about wicked problems, these things where there's no one simple solution, but we know that we can do better. So you've probably all seen these sort of images before, but let's just talk about what equality is. So equality is where everybody's treated the same and everybody has the same supports, but it doesn't mean that it's fair. So we talk about equity. We're bringing in the element of fairness into it, so everybody gets the support that they need. And then when we talk about justice, we talk about removing structural barriers, and the causes of inequity are addressed. And then we come to talk about health inequalities. So there's multiple definitions of inequalities and of equity. So I like this one for health inequalities because it talks about systemic, avoidable, unfair differences in health outcomes observed between populations, between social groups in the same population, or as a gradient across a population or a social position. So when we look at a gradient, we see people with less resources, less income, less education, less power, have poorer health. So to change this, more resources need to be given to the people with the least resources than to the people with the most resources in order to address this. And that's really complicated and difficult to do. And here's some definitions of health equity. These are hard to read now. Just look at this is one that's supposed to take you 30 seconds. These are supposed to take 8 seconds to read. So health equity means everyone has a fair and just opportunity to be as healthy as possible. Or health equity means removing the economic and social obstacles to health, such as poverty and discrimination. So health inequality is also talked about as syndemic. This word became well used during COVID. Syndemic brings the ideas of complexity. It's an aggregation of interacting diseases, ill health, social and environmental factors that promote and exacerbate the negative effects of each other. So COVID, an infectious disease, interacted with a wide range of non-communicable diseases, from heart disease and obesity and diabetes and chronic respiratory diseases. And there was clustering in specific populations linked to patterns of inequality that are deeply embedded in all of our societies. And this overlaps with the concept of donut economics and the overreach that we've heard about already. So many of you will be familiar with this, that nearly 20 years ago, the World Health Organization set up the Commission on the Social Determinants of Health, chaired by Professor Sir Michael Marmot. These are defined as the conditions which influence our health, the conditions in which we are born and what happens before we're born, where and how we grow and learn, where and how we live, if we have a home, where and how we work, if we have work, and how we age. And there are many models, we've seen some already this morning, to describe these interconnections. You'll be familiar with this one, which is in Healthy Ireland. But we also need to appreciate that healthcare services and health-related behaviours are only part of this whole picture. We need to consider actions on the wider environment in its broadest sense, including these complex intersecting domains that influence our health. And we've heard already that only between 10 and 20% of the population's health and well-being is related to healthcare. We need to consider housing, education, access to green and blue spaces, the food we eat, how we travel, how we work. And we have some influence in some of these behaviours, and we can advocate for wider changes. But risk is never determined by individual behaviour alone. Susceptibility is aggravated by social factors, by poverty, discrimination, and inequality. And some actions that we take can actually worsen inequality because sometimes poorer people have less capability to engage or change. And another complicated model in this one's around the commercial determinants of health, which are defined as the systems, practices, and pathways through which commercial actors drive health and health equity. So this includes goods and services and the environment in which commerce takes place. And the recent Lancet Commission on the commercial terms of health tells us that 1/3 of global deaths are attributable to commercial sector products and practices. And the big four in this are tobacco, alcohol, food, and fossil fuel. And we've heard references to all of them already. When I mentioned the Commission on Social Determinants of Health from Sir Michael Marmot, so they had this very compelling conclusion. If you think that this is a UN publication, there was consensus to be able to publish this, that social injustice is killing people on a grand scale. The Commission described actions to counter this about improving daily living conditions, tackling the inequitable distribution of power, money, and resources, and then measuring and understanding the problem and assessing the impact of actions. In Ireland, with the Healthy Ireland Outcomes Framework as a way to do some of this. Marmot went on to develop reports for the UK and the WHO European region underpinned by this concept of proportionate universalism. So going back to that gradient, the actions and services should be universal, but with a scale and intensity that is proportionate to the level of disadvantage, with the most disadvantaged receiving more resources. So closing this gap requires outcomes for the most disadvantaged to improve faster than for the more advantaged, which is very challenging. He also describes policy actions across the life course, including incorporating equality and equity into all policies. And he mentions capabilities. So going back, there's been several references to agency already this morning. I won't read all of those. So who experiences inequalities and disadvantage? Well, in this syndemic, we have people who are poor, people who are deprived, we've got socioeconomic status, interacting with vulnerability. So we've got vulnerable groups, we've got people who are addressed by inclusion health services, such as people experiencing homelessness or people coming out of prison or vulnerable migrants or other groups like that. Then we've got the people who are discriminated against on any of the 9 grounds described in the Equal Status Act. And then not forgetting urban-rural and other geographic or environmental challenges and inequalities. So to address any of these things, we can only improve things that we can measure. So what are we measuring? To know we're tackling the determinants of inequalities effectively, we need to be measuring them properly. So the lack of data is a huge issue for us. And we've seen some brilliant data already this morning. We're going to hear about more. But we need to look at other ways. We need our understanding of the scale and nature of inequalities and the impact of our interventions is limited. We need to know what policies actually improve health and are working and what's not inadvertently widening inequalities. And we know there's huge inequalities here. Like recent headlines show us great successes and severe problems just in this country alone. And there's a clear link between inequality and vulnerability and the climate crisis, the biggest challenge to all our health. We've heard already about how disadvantaged groups have more exposure and vulnerability to climate hazards. In terms of healthcare then, the inverse care law was described just over 50 years ago. It tells us that the availability of good healthcare tends to vary inversely with the need for it in the population served. This was reworked for the 50th anniversary of that publication to talk about disproportionate care. So innovations like deep end GPs aim to address this. Like in Scotland, deep end GPs get additional resources and additional funding for the 10% most deprived populations. In Ireland, deep end GPs self-identify and are looking for other resources as well. But these sort of things can be applied to other sectors as well. Underpinning all of this is the right to health and rights-based approaches. So this includes considering aspects of health services, such as the availability and disease services, as Carolina said. So the availability, accessibility, affordability, and quality of health care, but also attention to all these underlying determinants of health, and public participation, non-discrimination, gender equality, and access to information for people. In Ireland, we have the public sector duty. The public sector requires all public bodies to assess, address, and report on its actions to promote equality, to eliminate discrimination, and to protect the human rights of both service users and staff. And the new latest HSE National Service Plan commits us to new actions on this. Just an example of something related to that, if we talk about access, this is a model used for describing access to healthcare. At the top, you see things around the supply side of healthcare, like the availability, the acceptability, the accommodation, the affordability, the appropriateness of care. And the other side, you see the demand side, and this is about abilities and agency. So the ability to perceive a health need, the ability to seek care, the ability to reach, to pay, and to engage. And we can apply something similar to green and blue spaces. With colleagues in Galway a few years ago, we contributed to a report for the EPA, the European Environment Agency, on access to green and blue spaces. And we looked at this in similar kinds of ways, around the supply of green and blue spaces and the ability to engage with green and blue spaces. And we need to be thinking more in other ways like this. And again, linking across all of these ideas of sustainable healthcare that we're going to hear more about in shortly, we should also note that preventing disease reduces the use of healthcare and is the number one principle of sustainable healthcare. So when I'm talking about what comes together, this idea of health and all policies, and that everybody here, and that I hope you can see that everything connects and that we're all working for the wider public health. Reducing health inequalities is goal 2 of Healthy Ireland. And Sloanshire Care has explicit actions on partnership and cross-sectoral working, including the Sloanshire Care Healthy Communities, which focus on the most disadvantaged communities. So what I'm saying, and you've heard all of this before, is we need to be thinking more about upstream to prevent those children and adults falling in and drowning. And the kinds of things that we need to be doing. And we've been hearing already about joined up working. We need much more joined up action on the wider determinants of health. We need to really take that idea of proportionate universalism to heart, more resources for the people with the biggest need. And we need to develop the wider public health workforce and public services and NGOs and others, and engage with the idea of the public sector duty. And we need joined up measuring, monitoring and evaluating to work out what really works. So we need to be measuring and evaluating things better so that we will know what works. But the research evidence for these sorts of things is typically under-resourced and under-researched. And the evidence isn't there to give us high confidence of what works. So we need to improve on top of all of that as well. So goal 17 of the SDGs we've seen already is about partnership and working together, as in the idea in One Health, thinking, healthy animals, healthy humans, healthy ecosystems, thinking across society and sectors and disciplines, everything coming together to improve what can work. And our evolving vision in the HSE, public health and health improvement, is to make health equity everyone's business. And we need to be assessing, addressing and reporting on all of our actions and working together with everyone else. Going back to the central message of the SDGs, which is about leaving no one behind. So we have to see that there are new opportunities to build on public and community involvement and participation. And in the words of the disability movement, nothing about us without us. So basically, improving health, acting on the determinants of health, and reducing health inequalities is all of our business, and we all need to work together to make this happen. Thank you for your attention.